I'm Laura Bonnell, and this is the Living with Cystic Fibrosis podcast coming to you from Detroit. Please subscribe and even rate and comment on our podcasts when it moves you. I learn something new with every podcast, and I'm always inspired by the people that are showcased here. We don't give medical advice. You need to connect with your doctor for that. I hope that this Living with Cystic Fibrosis podcast educates you and sparks some volunteering or advocacy. The CF community needs people like you. Thanks to our sponsors, Viatris and Vertex, for their support. Today on the show, we are diving into the cutting-edge world of medical imaging, specifically how it's being used to help children with rare genetic diseases. Our guest is Dr. Chris Flask, a professor of radiology, biomedical engineering, and pediatrics at Case Western Reserve University and University Hospitals of Cleveland. Dr. Flask leads a research team that's changing how we see and treat complex conditions like polycystic kidney disease and cystic fibrosis. His team is developing powerful new MRI techniques that are fast, accurate, and get this, require no sedation, no radiation, and no contrast agents. And that means clearer, safer scans for kids in under 15 seconds per image slice. Supported by the National Institute of Health, the Cystic Fibrosis Foundation, and a remarkable 42-year collaboration with Siemens MRI, his work is definitely paving the way for multiple center clinical trials using these new imaging tools to track disease progression and response to therapies like never before. We are so excited to get right to it and welcome Dr. Flask. Thanks, Chris. I am so glad that I met you at the Ohio Valley CF Consortium, not too long ago, a couple months ago. There are so many amazing people there, and you're definitely one of them. So thank you.
Well, that's really nice of you. And thanks for the invitation. I really appreciate it. This is going to be fun.
I'm glad you joined us. And I just want to say off the bat, you are a doctor, but you said to please call you Chris, which I really appreciate that, but also want everyone to know that is your preference. And it is refreshing. And why do you do that?
So from my perspective, too many titles and too many initials creates barriers. And one of the most important things in CF and a lot of things that we do is our team. I am just one part of everything that is going on here at Case Western in terms of our CF research program. I'm just one of many. And those many include students and undergrads and nurses and MDs and a variety of other folks. And from my end, why do I need to add to any barriers into that? I want to learn from everybody as well as teach. So it's really important to do that.
And I love that. And I've just in the past couple of years been able to not call people doctor and call them by their first name. It's like calling your first grade teacher. You've been calling them Mrs. Reamer your whole life or whatever, sure. And then she wants you to call her by your first name. You're like, what? I can't do that. But I appreciate it. And I have to tell you, one thing that I tell new CF parents when they're picking a doctor, one of the first things I say, because they'll always ask me, how do you know if it's the right doctor? And I do always say, call them by their first name. If they have a problem and they want their title, like, whoa, I'm a doctor, then you've got the wrong person. I always respect everyone. And I do address them in clinic as doctor, but as a way to figure out if someone is good for you, that kind of is a good little, test of if you can work and be one-on-one with somebody.
It is, and like everything in life is about relationships and how do you integrate those? And again, like it's easy to take in my case, a PhD in engineering and say, Chris is this or Chris is that. But when you just say look, I'm just one person trying to learn and trying to help make care for CF patients better one day at a time.
Well, thank you. And I have to say, I had to go to ChatGPT to dumb down for me, the materials that you sent me, it made no sense. And I heard you speak, and I understood it when you were talking, and your medical partner when she was talking. And then I was looking through the materials, like, oh my gosh, I don't understand any of this. So I put it through Chat GPT, and I was like, oh, okay, I love that. It was really cool. So kind of tell us what you're doing, because it's very exciting. I guess the first thing that caught my attention was a fingerprint for an
Yes.
MRI. Yeah.
Yeah. So this MR fingerprinting capability has really emerged over the past 10 years out of our MRI research program here at Case Western Reserve. And very rarely can you say this in life, but this is really a transformative thing. It's different. And I'm, again, glad to be a part of it. So my whole goal in my career is, we think of MRI and CT and ultrasound as a means to detect disease. Well, it's different when you start thinking about kids with genetic diseases, right? We know they have CF. We're not really detecting something there. But what we want to do is measure and quantify different aspects of the disease so that we can say, are they progressing quickly? Are they progressing slower? And then in the age of modulator therapies for people with CF, are they responding to the therapy? What are we doing inside the body? We know that they're breathing better. We know that they're feeling better, but what's going on in the lungs? And so my goal as an imaging scientist is to help visualize that and quantify that. And we think of all imaging as well as being in a radiology department where we get these images and they get sent off to a radiologist. And typically you get a binary answer from that radiologist. So you either have disease or you don't have disease. And so there's really no mechanism in clinical radiology right now to be able to do these kind of metrics that we want to do for people with CF. So how do we measure their lung disease over time and in response to therapy? How do we look at the liver and pancreas and in the gut for people with CF over time, especially as they're aging? So our goal is to turn imaging, instead of just like image creation, into data. We want to create numbers so we can say, this is what's going on in the lung. And when we put these patients on modulator therapies, we can see a 10% improvement in their lung disease specifically. And we can see similar responses in the pancreas and in the liver and the gut, like I was mentioning. And that's our goal here, is to quantify it through this fingerprinting methodology. And again, like this is a new thing. What's really interesting with it, it's extremely fast. So we think of MRI session scans as being like go into an MRI scanner, which is going into a scary tube for like an hour, and it takes, and then you get some image sets that go to the radiologist. Well, fingerprinting generates data, not images. It generates data in 15 seconds per imaging slice. Okay, it's a different paradigm altogether. It's a different scale because it's so short and fast that you can get rid of some of the artifacts that have plagued MRI for the past 40 or 50 years. You get rid of the respiratory motion artifacts. And for kids that are like, 6, 7 years of age or even younger, typically, because it was an hour-long scan, you'd have to sedate those kids to do those MRI scans. Well, now we don't have to do any of that. We can flip a video onto our MRI scanner. We can complete the entire MRI scan of the lungs in less than 5 minutes. So it's a complete different paradigm. And again, on top of the quantification that we're getting of the disease. So that's kind of how this fingerprinting plays into this. And on top of it, with all of that reduction of sedation and motion and all those things, and there's all these other MRI quantification errors that we know about from 40 or 50 years of use, fingerprinting's reproducibility is now down to 3 to 5%, which means if you get data on one day for a patient, the next day you're going to come in, and we expect it to be less than 5% for sure variation, which is incredible from an imaging standpoint, because that's about 5 times less variation than we get from conventional MRI methods.
What do you learn? I just keep writing notes down
Yeah, yeah,
so I
yeah.
don't want to forget things while you're saying this, but what do you learn differently? Do you need to see the lungs, or you're getting information that's
It is.
describing everything?
Yeah, it is different. MRI and these fingerprinting scans will give us the ability to see where the blood flow in the lungs is going or where it isn't going in particular. As you think about like regions of the lung that have airways that are um, damaged from chronic infections. Well, there's no reason for your body to send blood to that region to get oxygen transfer because it's not there. So what your body does is ends up shutting down that blood flow locally in those regions that are fibrotic. And so with fingerprinting, we can measure that blood flow, which is a measure of the local disease going on in that patient. And so it gives you unique information in that space. And so you're not just measuring the ability to breathe through a tube, which is spirometry, you're actually measuring local disease. And that's really important because we can breathe into a tube and we can train ourselves to breathe better through a tube and feel better. But are you really getting rid of the disease or not that's in the lungs? And this is what MRF provides you with this kind of quantification.
So, and if I am understanding you correctly, then you're getting possibly more detailed information.
Oh, completely.
Okay, than you would get just by seeing with a picture. Yeah.
Right. It's not, the pictures are great because it allows you to localize it, but then you can quantify it on top of it. So it's kind of both those features that you can see here. And again, for folks that aren't aware, MRI has no radiation. It's not like CT, right? That's going to irradiate your body every day. And when you go in there for those scans, there's no radiation involved. There's no ionizing. There's no cancer-causing medium in MRI. It's as long as you have you're safe to go into MRI, which is a strong magnetic field, then it's perfectly safe for human beings.
It is incredible. And just the time alone that it'll save if you have little kids or if you're a parent who has kids with some chronic illness and you just need to like have something done quickly. How far ahead is this? How soon could it be a reality?
Well, so fingerprinting is now FDA approved on Siemens MRI scanners in the brain for certain instances. So it's coming, and it's coming quickly. So expanding the application to the lungs and in the liver and the pancreas for CF patients is a matter of adding on to that technology as we go through it. And one of the things that's really sped this along on our end is our MRI research team here has a 42-year research agreement with Siemens. I was 13 when that agreement started, right? And so and this is part of also this team-based approach and this mentality is like, I didn't establish that agreement, right? This was everybody with me and before me. And so that agreement allows us to program these new technologies like MR fingerprinting on the Siemens human MRI scanners that are already FDA approved. And then those specific packages and those quantifications that we're talking about can then go for approval in the next round of FDA assessments submitted by Siemens. So it allows us to do these things. And Siemens is one of the world leaders in MRI manufacture. So you can go to many academic institutions and find a Siemens MRI scanner. And that's throughout the world. So once we have FDA approval, this will be something that can be a rapidly deployed screening tool for any person with CF.
And it is incredible, but you still need grant funding, or is it all covered by Siemens, or how does that work?
Oh, we still need grant funding for sure. So Siemens supports us kind of like in kind. They give us access to the software. They give us access to high-end MRI systems that we wouldn't otherwise get. And because of that, the cases actually co-localized with the University Hospitals of Cleveland. And so in the Department of Radiology where I reside, we have dedicated research time on these MRI scanners from essentially 7 a.m. until 8 p.m. at night. And so it's ours first as a research team because of this research agreement. We're not trying to like recruit and do studies with CF patients at 2 a.m, like many studies, like many groups have to do. We're not trying to work around the clinics. It's ours first. So that's the first step in that space. This is what kind of that access provides us. But the grant fundings on top of that still have to go forward, because we still have to pay the students and postdocs to do the studies, right? And relative to others, they're relatively cheap, but we need to recruit the best, right? We don't want to recruit just anyone. We want to recruit the best students who can become the next leaders. Like I mentioned with this 42-year research agreement, I was recruited in as a student. I became a graduate student and faculty then eventually, but we want to actually recruit in the next round, right? Who's going to come after me to see this through? That's what the grant funding really is about.
Right. And it's so important to make sure you leave the future generations better off. And so much will have changed by the time this podcast airs, but I wonder, are you concerned, or do you feel pretty confident that the funding will be around? I mean, things are a little bit different, this year.
Yeah, and I agree with that. And I said it from my perspective, there's certainly concern, but I do think that the preponderance of the data shows the overwhelmingly positive impact of research, both on patient care and on the economy in this country. And these are just like pillars of our society, right? And it's not something that we're going to be able to, like, we're worried about like the level of funding, but seeing funding go away, I think that's foolhardy. Right? So I don't think that's even possible, which is good. But it doesn't mean we don't need to advocate for more funding to keep going forward. To me, it's not politics. To me, it's all about the patients. And
I agree.
So it's like we got to stop thinking about politics, and so we just need to be focused on the patients. What we need to do to improve their care.
It's so futuristic. It's so exciting. I mean, this isn't just going to help cystic fibrosis and polycystic, the kidney disease that you're also, it's a game changer for everyone.
Yes. And this fingerprinting work that we're doing right now, I think I sent you some of the papers that are in cancer realm as well. We're seeing this data have a huge impact already in brain and prostate cancer patients. And I'll use an example here. Our current data in patients with prostate cancer shows that our quantitative fingerprinting scan, again, the 15 seconds per imaging slice, has the potential to eliminate 60% of prostate biopsies every year.
Wow.
Like forever. And the data that we're showing in breast cancer patients right now suggests that we have the ability to determine whether or not neoadjuvant chemotherapy is working in many patients with breast cancer after a single round of chemotherapy, given that they get 6 to 8 rounds of that chemo. Boy, wouldn't that be nice to know if it's not going to work early on, so that you can A, eliminate the rest of those rounds of harsh chemo, and then B, get them onto something better. Right. So these are things that are going to come really quickly out of the fingerprinting realm. And that's in addition to all the genetic diseases things that including CF and polycystic kidney disease, like you mentioned. It's an extremely powerful tool. And that's why I said it's very different.
And for everyone who has to have a mammogram, I do have a question. It may be off track, but instead of being smushed in a machine, like, is it possible this would be an alternative?
Oh, and that's how we're looking at it. So I'm highly motivated in the rare genetic diseases world, because in CF and PKD, because I care about these. These are kids, right? And we're all adults, and sometimes we cause our own diseases. We are our own worst enemies with our diet and everything else that we do in life. But breast cancer is awful in particular, and so how do we look at mammography with its kind of low sensitivity to detect disease, and how do we apply fingerprinting here with these 5-minute scans that we're talking about that are non-irradiative, much more comfortable, and maybe contrast free down the road, so you don't have to inject anything. So just lay down for 5 minutes, get a scan, and walk away. And the data shows that MRI, and that's not even fingerprinting, just MRI by itself detects 2 to 5 times more cancers than mammography. This is
Wow.
known, okay? And with fingerprinting added on, the specificity becomes even better. So you're getting maybe 90% accuracy, which is unheard of in this realm. And can you think of a world where we would never detect late stage breast cancer? We would only detect it early? Can you think of a world like that? Wouldn't that be amazing?
It would be incredible.
Right?
I
So
mean,
these
it's
are,
a, yeah, game changer is all I keep
right.
thinking about
Yeah.
every time you're telling us something. And, you know, when we were sitting at the table at the consortium, everybody was very interested in what this would mean for prostate cancer. I mean, my
Hmm.
dad died of
Yeah.
it 36 years ago. And I think, wow, for men now, this would be another game changer, right?
Right. Absolutely. Absolutely. And as I said, the data's there. We've got publications and new data in all of this, and we can act very accurately see disease versus non-disease, but we can also stage the disease. And in prostate cancer, there's a couple of tiers. There's more aggressive disease, which you have to really be careful with and aim more towards surgery and therapy, but there's a more indolent disease that is really slow growing. And what's the point? Are you going to irradiate somebody and give them chemo and do surgery for someone with an indolent disease when they're 80 years old that may never progress? And so these are things that AMR fingerprinting is able to do as well, is to separate that indolent disease from the more aggressive form of disease as well. So it's kind of that precision, that reproducibility that I talked about is incredible, and it allows you to really tease out some of these subtle differences that we would never been able to see before.
And what interested you in this field,
Mm.
and how did you get drawn to it? And I'm also always curious, you know, once somebody invents or discovers or puts it out there, it seems like, oh, we've had it forever or it's easy. But you and your colleagues are thinking of things that we've never
Hmm.
done before.
Hmm.
I mean, pioneers in medicine, in research, and it's incredible to me.
So I was a chemical engineer as an undergrad. And so after graduation, I started to work for a chemical company here in Cleveland, and I loved what I was doing, but I was there for 7 years. And I think I told you this. I said my wife is an MD. She's a pediatrician, and I would go to dinners with my wife and many of her resident friends, and I'm sitting there. I have no idea what she's talking about. I said it's a totally different world. And so it was a little bit self-serving. I'm like, I really want to learn more about biomedical engineering and more in this field, a way I can, get closer to my wife and where they're at in their space. But also it's intriguing. I'm listening to the stories and they're amazing stories. So I came back to Case and got my PhD in biomedical engineering. And my specific focus was on MRI development. And the reason I loved it was because when I first was exposed to it, I was amazed about the diversity of things that you could see with it. There and I really describe MRI in general as like a 40-dimensional Rubik's Cube that you have as an engineer, you have to put all those dimensions together in the right way to be able to see pathology and to be able to see normal tissue and see the effects of therapy. And it's like, wow, this is kind of fun, right? It's like just an enormous puzzle. So I was hooked from the beginning. I'll be honest with you. I'm like, I love this. This is really cool. And so I said, and anybody that likes really challenging puzzles, MRI is just that. And so I got hooked in the beginning. And what was really nice when I came down to do my PhD here is again, the graduate students in engineering sit right in the Department of Radiology, about 20 feet from the human MRI scanners in the clinical bays. So think about what that means as an engineer, right? Typically, you think them sitting in there with a calculator and a board and you're drawing stuff and doing. We're not doing that. We're sitting right next to patients, right? This is pretty amazing and impactful. And for us, like we really learn from day one what it means and the impact that our science and our physics knowledge, how we can actually impact patient care right now. And that is so unique. But that's what I love about it. And you talk about fingerprinting, how fast it's progressing here. it's moving so fast because of that environment. And our team here is MD radiologists and pulmonologists and nephrologists and geneticists and MRI physicists and everybody in between. So it's a lot of fun. And when you bring that kind of multidisciplinary team together, the magic out of it is amazing. And especially when those folks really try to lower their ego again and drop those titles and let the bears in and ask really basic questions. Because when you can cross disciplines in your discussions and in your science, boy, that's just incredibly powerful.
It is. It's like we are watching the future. I mean, where do you think the potential is for 10 or even 20 years from now with this?
I actually say 5 to 10, because I'll be honest with you, this is going very fast and it's picking up speed. I say in the past 10 years, fingerprinting went from an interesting idea to clinical applications, and we're seeing data now that should come out in the next 6 months or so in a publication to maybe JAMA or something of that level that shows that fingerprinting can replace the standard of care for some patients with breast cancer. I mean, these are the kind of data that are going to come, and when those kind of landmark publications hit the mainstream, people are going to demand that the standard of care change. People are going to demand something better than mammography, like you mentioned previously. And that momentum can't be stopped, right? And that's why I said, like, I think the next 5 years is going to be a lot of fun. So
That
it's going to be
is
fun to watch.
absolutely. And are you required to do anything like clinical trials
Oh,
or
absolutely.
okay.
Yeah. So and so I view them as clinical imaging trials and prospective studies and things like that we have to do. And again, it comes back to your question about grant funding. That doesn't happen for free, right? There's scan time, there's multiple centers that you want to engage in here. We're working with the Children's Hospital of Philadelphia. We're engaged with folks at the University of Chicago and Northwestern on some of the PKD work, and then folks at Indiana and folks at Michigan and also at CHOP on the CF side of things. So you've got to do these multi-center trials, and you need more people involved, and you need to build out those studies to verify all this. All the preliminary data in the world does not answer the question. You have to go and absolutely nail it. And as I said, and that's what you have. That's the next step. So that's where that grant funding really comes in now.
It's very interesting, and you always learn things through this. I mean, with CF drugs, there was always like, okay, we tried 5 different ways or 5 different, ways to do it and one worked. What are you learning from this whole process?
So I think it's really interesting, right? And I come back to the breast work that says that like maybe we have a way to look at the impact of therapy early on. And also because it's so fast, you have the ability to assess multiple organs. So we think ahead to like gene therapies for different diseases. Well, one of the challenges in gene therapies is off-target side effects, right? And so you may be wanting to treat the lung, but it has a negative impact in, let's say the liver or the kidney. With fingerprinting, you can assess both sides of that. You can see the efficacy directly in the lung, and you can measure potential side effects in other areas too. It gives you the chance to sort of combine all of those into a more thoughtful approach so that we know, A, that these therapies have a benefit, but we're also not causing too much harm either, right? And again, like, the Hippocratic Oath, do no harm, right? And I said, so this is also something that we got to keep track of in this space, because it's easy to want new therapies and like you think ahead, back to when modulator therapies came along for people with CF. Well, these people are going to die if we don't do something, right? What are we going to do? And so, okay, now we have the opportunity to go like, okay, so what's the next phase? We think we have treatments for at least 90% of the people in the lung. What are we going to do for the lung for the other 10%? And then what does this mean when they are living longer? What do we need to be worried about? What are the next phases in this space? We don't know, right? And we need to be cognizant of it and thinking ahead, so we're not trying to react to what we're going to find over the next 10 years in CF.
And you just touched on what I was going to ask you. I would think with all this information, not just cystic fibrosis, but also PKD and breast cancer and prostate, we're all going to live longer, right? Because we will be able to, like you said earlier, be able to see this in
Yeah.
much earlier stages.
Yeah. And the early stage is the biggest thing, right? And so I'll use the PKD example here, our recent publication in patients with the autosomal recessive form of the disease. We're able to completely delineate early disease from healthy volunteers. And this is the first time we've ever been able to see that in these patients. And so we think about clinical trials of new therapies for these patients. Without this MRF methodology, those early stage patients wouldn't even be able to be enrolled because we can't even see their disease to monitor it. Does that make sense?
Mm-hmm.
And and isn't that the group where you want to treat? Right? Isn't that the group you, before that disease causes huge damage, you want to treat it early? And so that's the group that's so important. And now we'd be able to see that early disease so finely and so reproducibly. That's absolutely got to be our target. And again, thinking ahead and using the CF sort of in an analogous sort of way, if we're just trying to treat patients with 30% lung function, good luck. They're not going to live another 30 years, right? So we need to be treating them when they have 100% lung function.
Right.
So it stays there, right? And again, so this is why this becomes so important.
And this is really, isn't it fair to say, preventative medicine to
Yeah.
some degree?
Yeah, it's preventative and individualized, right? And this is the cool part about it, right? You're measuring that person's lungs. You're measuring that person's kidneys. And it's like these are things that we really need to get back to. The challenge in all of it in history has always been like, how much is it going to cost, right? And today, that's one of the biggest issues when we turn on the news every day.
Mm-hmm.
Well, and again, if we think of MR fingerprinting being a 5-minute scan instead of an hour scan, you've cut the cost down by a factor of 12 immediately, right? So now we have MRI scans instead of costing $1,500. How about $200, right? That's different. That's different. And you actually have the volume or you actually have the throughput then to be able to get more patients in a reasonable time frame. So all of these things are on the horizon here. So it's not just the science and it's not just cool. It's actually economically viable as well.
I mean, that's going to make everyone happy. The insurance companies will be happy. That's going to save our copays. That's going to save all of us so much money.
Yeah, absolutely. And so these are things that all need to be tracked in this space. And that's why I said, like, seeing how do you handle the viability of this new technology, not just from a scientific standpoint, but from an access standpoint. And these are things that have to be kept in consideration in all of this. And again, this partnership with Siemens right now, this is what we're actually working with their economic and financial analysis team to sort of look at this and see that, yes, is this viable? Is this meaningful, not just scientifically, we know that, but how does it fit into the clinical workflows and can we have a real clinical impact? And so those questions have to be answered as well, and that's what we're doing.
I think it's so interesting, and I feel like we're glimpsing the future 100% for sure.
Absolutely.
It's very
Yeah.
cool. Is there anything that you wanted to mention that we didn't touch on about where you're going with this?
Now, I have to share your enthusiasm. Is that I'm so excited to just be a part of this, right? And is that and I grew up in Northeast Ohio, and to see this kind of transformation coming out of the Cleveland area is just, it makes me happy. It makes me very happy and completely humbling to be a part of it, right? And it's just like, and I'm going to do my best every day, right? And as we scan every child with CF and every child with PKD, you know, do I need any more motivation? No, not at all. Not at all. Right. And so it's like every day this is fun, and if anything else, my wife has to yell at me to stop working once in a while because it's a bit addictive in some ways, right? Because you just want to help more and more and more.
Well, I love your enthusiasm, passion, your knowledge, like all of that. We're so grateful. And everyone that hears this is going to be so grateful. Such a selfless person with so much knowledge, and you're doing all this work and moving us all forward. So thank you so much for sharing it. And I'm so glad I met you in person before we did this podcast.
Yeah, same here. Same here. It's good to meet other people. And again, you exude the same passion for this space too. And I appreciate that. And that's what I said. Like finds like in these situations. Yeah, so I appreciate it. It's just so much. If you can't be excited about this from my own perspective, then shame on you, right? As this is really compelling and fun stuff.
It's just going to have an absolute fabulous impact on all of us in so many ways.
I'm sure of it.
Thank you.
Not a problem. Thanks again for having me.
You're welcome. Glad to have you. The original music in this podcast is performed by Kevin Allen.
It's not complicated.
Who happens to have cystic fibrosis.
We all got our worries and fears. I know it's got you frustrated, but loving you is so alright.
This has been the Living with Cystic Fibrosis podcast. For more information and to learn more about the Bonnell Foundation, visit our website at thebonnellfoundation.org. That's the BONNELL Foundation.org. This podcast was sponsored by Vertex Pharmaceutical, The Science of Possibility, and Viatris. It was produced by Jag and Detroit Podcasts. Follow our show in Apple Podcasts, Spotify, or wherever you're listening right now.